This is the lecture on the vertebral column and the muscles of the back. Lecture objectives. We are going to look at the following parts of the back in this lecture. We're going to do some osteology, identify the bones that are associated with the back and the vertebral column. We're going to be able to articulate the differences between the various types of vertebrae and the associated structures. Understand the function of the various processes associated with the vertebrae. Know the vasculature of the vertebral column. Identify and understand the function of major ligaments of the vertebral column. About the muscles, we're going to try and be able to identify the various muscles of the back and understand their functions based on their origin and insertion. You might also stumble across the terms proximal and distal attachment, which are probably the more modern term to use. Also know, of course, the innervation and the general vasculature that supplies these muscles. And of course, we're going to try and delve a little bit into clinical correlations, specifically understand the clinical implications to common pathologies associated with the osteology, the spinal cord, and the musculature of the back. Let's talk about anatomical planes first. It's going to be really important for us to be able to communicate with each other clearly if we want to talk about the anatomy of our anatomical donors or even our own or patients. We need to be able to understand what the different planes are and what terms are used to describe different planes. Okay? Quite intuitively, we have anterior and posterior. In general, I would just say that's the front and back, anterior and posterior. You could also say ventral, which is used more often in biology, and dorsal for the backside. If we think about planes, you can see here indicated by the blue, well, kind of like semi-transparent rectangle here, that is the frontal plane. It is also called the coronal plane. So any plane that intersects the body from left to right and creates unequal halves, clearly because the front and the back half are unequal, is going to be sectioned in the frontal plane. The only plane that will ever intersect the body and create two equal halves, although of course mirrored, is going to be the median plane. Okay? If we move the median plane slightly off to the side, so not right through the nose, that would be called the sagittal plane, as you can see indicated here. So any kind of plane that you see that is slightly off kilter, off of the median plane, will be called a sagittal plane. In addition to that, there's a plane that you probably will have already seen. Basically, a lot of MRI and CT images are done in this plane, which is called the transverse or axial plane. Yeah? When looking at CTs and MRIs, and you see this is taken in the transverse plane, do remember you are viewing it as if you are standing at the foot end of the patient's bed and looking towards the head. Yeah? So that means you will actually have a slice through here, and imagine that the head is like furthest away from you. That's how you can identify that plane. And of course, if you then put together a good picture of the anatomy, if you understand where different organs, bones, muscles, nerves, blood vessels are, and you see sections, you will, over time, not immediately, but over time, be able to piece together the three-dimensional arrangement of our anatomy in our bodies. Here we're going to have some more terms that we should be familiar with. Superior, superior from the side. Inferior. Proximal means closer to. Distal means further away. I would, for instance, say the foot is distal to the knee. Yeah? The knee is distal to the hip. Yeah? The hip is more proximal to the belly button than the knee. Medial means directly in the midline. Lateral is towards the sides. Okay? If we look at this picture, I've already named the terms posterior or dorsal, anterior or ventral. Your thumb and your hand is distal to your elbow, for instance. Your shoulder is the most proximal part of your upper limb. If we look at a slice here, this is indeed a transverse section, and so is this CT image of the abdomen. So if you think of the muscle layers or the tissue layers here, you have superficial, and if we go deeper in, of course, it's deep. And in the middle here would be the bone. So we have superficial, well, actually we have intermediate, of course, the muscles, and then the bone, deep. On the hand, well, the back of the hand is actually called the dorsum, and the palm of the hand is, well, the palm. At least that one's simple. On the foot, the same thing, because feet are actually pretty similar to hands. The dorsum of the foot and the sole of the foot. In the CT scan, you can now see the scan was probably done at the level of the kidneys, so approximately here. And you can see in a flat 2D plane some of the organs and some of the bones and muscles associated with that body region. Over time, you will only have to take a brief look at an image like this and be able to tell approximately at what vertebral level you are. Let's talk about movement and body planes. Well, you see these movements that occur in this case at the elbow joint. This is flexion and extension. So to straighten your arm out like this is extension, and that, moving your arm kind of towards your shoulder, bending it at the elbow, is flexion. With the wrist, flipping it up and down would also be extension and flexion. Here you can see flexion and extension of the upper limb, flexion moving your upper limb forward, flexion moving your lower limb forward, and extension the opposite. Fingers too. When you curl your fingers like you're going to make a fist, you're actually flexing them. And of course, with your vertebrae and your vertebral column, if you bend backwards, kind of arch your back, that will be extension, and kind of curving yourself like a C is flexion. And flexion and extension can occur at the knee joint as well. Works like a hinge, so you'd have flexion and extension. It's fairly intuitive. Now we can get into slightly more complex body plane movements. Well, why don't we start over here? Moving something away from the midline is abduction. We often actually say abduction because actually abduction and adduction sound pretty similar phonetically. So abduction is moving your leg like this, like you're doing jumping jacks, like really slowly. Or your upper arm, your upper limb, I mean, moving it off to the side like this is abduction, and adding it back in towards the midline, adduction. Yeah, just think about it like this, adduction. Also, you can rotate your foot, for instance, or your hand. You can do lateral rotation and medial rotation. Lateral, follow the arrows, and medial. Moving your thumb toward the rest of the fingers is adduction. Spreading it off to the side like this is abduction. If you move your lower limb in a circle like this, well, it's kind of a mix of AB and adduction, so it's called circumduction. Yeah. If you move your foot towards the dorsal side of the foot, the dorsum of the foot, it is dorsiflexion. If you move your foot down, you plant it on the ground, it will be plantar flexion. If you move the sole of your foot in towards the midline, it is inversion. If you move it away, it is eversion. And you'll see that in and eversion do not work equally well. Usually inversion is, well, works much better, where you can actually invert your foot way more than you can evert it. Then you have flexion and extension with the thumb here. Here you can see that flexion actually leads to bringing your thumb to lie with the tip of your thumb towards your ring finger, and extending brings it out flat again like this. And then if you think about supination and pronation, a good way to remember this is actually think of supination as if you're holding a bowl of soup. You would clearly hold that in the palm of your hand, and if you then flip it over, well, you would drop the bowl of soup first of all, and then you would be actually in the pronated position. Supination and pronation. Next in line is osteology, so it's going to have to do with bones, right? So we're going to try and find out some facts about the functions of the vertebral column, its protection for the spinal cord. It acts as a support and attachment for the extremities, of course, and allows movement, flexion, extension, lateral flexion, and rotation. And most of all, it leads to a pretty significant stability of our entire axial skeleton. Important to remember, though, that vertebrae do not equal vertebrae, right? We have different regions. We have a cervical region up here with 7 cervical vertebrae. We have a thoracic region that has 12 thoracic vertebrae. We have a lumbar region with 5 lumbar vertebrae, a sacrum that is made up of 5 fused vertebrae, and the coccyx, which has 3 to 5 segments. This is actually a pretty good overview slide for you because you can see the different cervical, thoracic, lumbar, sacral, and coccygeal participants here. Remember that the coccyx, here it says it has 4 segments, but it has between 3 and 5. It varies a little bit between people. You can also already get a taste for the curvatures of the vertebral column. Clearly this is not straight, and there has to be some kind of rhyme or reason why the vertebral column has curvatures. You have kyphotic and lordotic curvatures, a lordotic one in the cervical region and the lumbar region, and a kyphotic curvature like a hunchback, the thoracic, and in the sacral region down here. Also, you can already anticipate that the shape and size of the vertebrae is going to change pretty dramatically. Well, one of the reasons is that the weight bearing increases as we go further down. So the strongest, biggest, most stout vertebrae are going to be in the lumbar region. Let's have a look at the curvatures in slightly more detail. The lumbar curvature is more noted in females, and it's actually exaggerated. It's called an excessive lordosis during pregnancy. The sacral curvature just below it here is also different in females. It's less acute, which also limits the protrusion of the coccyx into the birth canal. In the thoracic and the sacral regions, however, well, the concavity of the curvatures here is called an anterior kyphosis, while being posterior placed in the cervical and lumbar region, which is, again, a lordosis. Lordosis, lordosis. The primary curvatures of the back exist during fetal development. These are thoracic and sacral. They're maintained throughout life. But you can see that the cervical and lumbar curvatures during fetal life are also more like kyphoses, right? However, as we age, and that starts actually in young childhood, especially with developing an upright gait, these secondary curvatures of the back, like in the cervical and lumbar region, develop later on and are dependent on the growth and development of the intervertebral discs. The cervical curvature is noted as infants begin to hold their heads up. With the initiation of walking, the lumbar curvature down here will then start developing as well. So how's a vertebrae made up actually? Well, a vertebra in general would consist of several parts. It has a body, which is this pretty massive, bony, more dense anterior part. It has an arch, which consists of these pedicles and the laminae, so it forms something like an arch. And it has 7 processes. It has a spinous process. It has 2 transverse processes, and has 4 articular processes. There would be here, 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 and here. And the articular processes are superior or inferior, and they help the vertebrae connect to each other. Okay, the vertebral arch and the posterior aspect of the body creates the boundaries of the vertebral foramen, which, if we stack all the vertebrae on top of each other, makes the vertebral canal. Here we have a lateral view of a lumbar vertebrae. The inferior vertebral notch of the superior vertebrae in relationship to the superior vertebral notch of the inferior vertebrae will create the intervertebral foramen. Yeah? So if we stack another vertebrae below here or above there, these 2 notches together will create the intervertebral foramen, which is going to be the one that allows the passage of the spinal nerves. The articulating facets, here you can see the inferior articular facet, and up there is the superior articular facet. Well, these are going to be the ones that form a special type of joint. It is called, and this word is fun, zygapophyseal joint. These are very important in the movement of the vertebral column because the direction and the angle of these facets of the vertebrae that connect to each other is going to be the determining factor in what kind of movement is going to be allowed there. Okay, here we now have 2 vertebrae stacked on top of each other. You can see that the superior and inferior notches together will form the intervertebral foramen through which spinal nerves will come out. And you can see the zygapophyseal joint. It's actually also called a facet joint. They actually have removed some of the other connective tissue and ligaments around here There you can see you have the inferior articular process and the superior articular process. Don't be fooled by the fact that the inferior articular process is actually above or superior to the superior articular process. Just look at it. It's called inferior because it's inferior on the respective vertebrae. All right. I kind of like this image as well because it's using color coding to tell us what the functions of the different parts of the vertebrae are. Who would have thought that vertebrae that look like really simple bones actually have so many different functions or regions, right? So the green parts here are actually specifically for the attachment and movement of muscles. The blue parts will restrict movement. The red parts here, this was the arch of the vertebrae, and that will help protect the spinal cord. We all know that's a very sensitive structure. And we have the body, well, that'll support weight. Now let's have a look at vertebra C7. It's also called vertebra prominence because it usually has a fairly prominent spinous process. Here the body is going to be the smallest of all the regions of vertebral canal. The vertebral bodies of C3 through C6 actually have an elevated margin. You can see it here. It's called an uncus or uncinate process, while you can have bone spurs form in those areas that can result in neck pain. Also, the vertebral foramen is more or less triangular in shape, and it's large. The transverse process of C1 through C6 here's the transverse process. They have foramina. Foramina is the plural of foramen, not foramina or foramens. It's called foramina. And these foramina are really important because they allow for the ascension or for the passage of the vertebral arteries, left and right. The spinous processes of C3 through C5 or sometimes C6 are often bifid in nature. The spinous process of C7 has a shape similar to the thoracic region, and it's called vertebra prominence. You can feel it on your own neck because, well, as I said earlier, it's the most prominent vertebrae. Okay, C3 through C7 are considered typical vertebrae. C1 and C2 are actually considered atypical because C1 and C2 are special. They're called atlas and axis. So why don't we have a look at those in just a moment? Also, in the neck region, flexion is the greatest. So now let's have a look at the atlas. Atlas is probably my favorite vertebrae. It's called Atlas and it comes from Greek mythology because, well, in Greek mythology, Atlas was a guy who was pretty strong. He could carry the whole weight of the world. Well, here's some food for thought. If he's carrying the world, what is he standing on? Well, that's also kind of besides the fact. So anyway, first thing here, its structure is ring-like. Yeah, it doesn't have any spinous process. It doesn't have a body, yeah, but it has rather an anterior and posterior arch. Here's the posterior arch, and there's the anterior arch. The superior articular facets of the atlas are going to be in association with the occipital condyles of the skull. Yeah, they create a joint which is called the atlanto-occipital joints. Axis is also pretty interesting. Axis is C2, and it is considered to be the strongest cervical vertebrae. It has a process called the dens, right here, or also called the odontoid process, and it's believed to be the long-lost body of C1. So over the course of evolution, it was incorporated from C1 into C2, and now it is actually the dens. This image is pretty good because it shows us how the atlas and axis articulate with each other. The atlas will pivot around the dens, which is back here, with lateral and medial rotation. The dens articulates with the anterior arch of C1. And actually, in the previous image, you could see there was a ligament going across the dens. They've removed it here. That ligament is pretty important because it keeps the dens in place and prevents the atlas from slipping back and forth on the axis. Actually, it prevents the atlas from slipping back and forth on the axis. Characteristics of the thoracic vertebrae. The body is heart-shaped. It has costal facets where ribs articulate here and here. You can actually also see it, where is it? Oh yeah, there's a transverse costal facet here and right here. And the vertebral foramina is smaller. The spinous processes are fairly long, and they have a posterior inferior slope that helps limit flexion, and the tip will reach the vertebral body inferior to it. Okay, T1 through T10 all have transverse costal facets where portions of the ribs will articulate. Okay, also the transverse processes here and here are fairly long. Lumbar vertebrae. Lumbar vertebrae, you can see that the body is pretty massive and dense. The spinous processes are blunted. The vertebral foramina are the largest in this region, and they're kind of like triangular in shape, right? And the transverse processes are long and slender. If you look at the orientation of these articular facets, here and here, if you imagine that you'd have two vertebrae that are kind of like sitting on top of each other, well, with the facets oriented like this, they are primarily going to allow for flexion and extension occurring between two adjacent vertebrae. The sacral vertebrae, well, usually we'd have about 5, right? And they're all fused together. They provide stability for your pelvis with the transmission of body weight via joints, which are called the sacroiliac joint, yeah, because they are between the sacrum and the ilia, yeah, which are the the large parts of the hip bones. Okay, the base of the sacrum articulates with L5, so here, and its anterior angle projects and is referred to as the promontory. The superlateral edge of the sacrum is called the ala, and ala means wing. You can also see back here you have the sacral foramina, which are holed in the sacrum, and that is where you can find some spinal nerves exit as well. At the bottom here, actually in life it's covered by a ligament. It's called the sacral hiatus. This is sometimes used to do injections, for instance, into the sacral canal for people that, for instance, have chronic back pain. Steroids can be administered like that as well. Intervertebral discs. So we have, this is now an anterior view, the anterior longitudinal ligament. Okay, so the anterior longitudinal ligament is a fibrous band that covers and connects the anterior surface of the vertebral bodies and the associated IV discs. It'll traverse from the pelvic surface of the sacrum all the way to the anterior tubercle of C1, including the occipital bone, so it spans the entire length of the anterior vertebral column. This ligament will limit the ability of the vertebral column to extend. Okay, we have on the other side of this the posterior longitudinal ligament. The posterior longitudinal ligament is not that wide and not as strong as the anterior one. It runs in the vertebral canal, so we're looking into the vertebral canal here, but it runs on the posterior aspect of the vertebral bodies from C2 all the way down to the sacrum. And it's important to prevent hyperflexion of the vertebral column and posterior herniation of the IV discs. If you think of the placement of this ligament and this ligament, if this disc is going to try and squish out, it can't go forwards or anteriorly. It can't go straight to the side, or it's unlikely because there's actually going to be bone in the way. We're thinking about the vertebral or the intervertebral foramina. Can't go straight posteriorly, so usually the herniation would occur in a posterolateral manner, right? Then we have ligamentum flavum. Ligamentum flavum, I think we can see a little bit of it here and here. That's kind of a yellow elastic ligament that will cover the lamina of the vertebral canal. And it's important to protect the IV discs during sudden flexion of the column. It'll also help preserve the curvatures of the column and assist with straightening the back after flexion. The IV discs actually consist of 2 different parts. One is called the annulus fibrosus. Annulus means ring. So it's a fibrous outer portion. And on the inside, you have something called the nucleus pulposus. Okay, the nucleus pulposus is the central core. It contains a lot of water, elastin, and proteoglycans. Considering the vasculature of the vertebral column, we're not really going to be dissecting that in lab ourselves, but you can review the arterial supply and the venous drainage here. Arterial supply is mainly by so-called periosteal branches, equatorial branches, and spinal branches. The venous drainage is via spinal veins. The internal vertebral, also called epidural venous plexus, there's an anterior and a posterior version of that. And then there's an external vertebral venous plexus, again anterior and posterior. In addition to that, there's also going to be some basivertebral and intervertebral veins. Here's a brief overview of the arteries. So we're looking from superiorly now. Here is the aorta, which is going to be the abdominal aorta, as this is a lumbar vertebrae. You can see there are coming off the aorta your equatorial branches, anterior vertebral canal branches, periosteal branches, a spinal branch of a lumbar artery, and the posterior vertebral canal branch. The veins of the vertebral column. Here is a posterior external vertebral venous plexus. You have intervertebral veins that are between the vertebrae, the basivertebral vein, and the anterior external vertebral venous plexus. From a lateral view, or actually, it's a median section, you have your basivertebral veins, and you have your anterior external vertebral venous plexus, and posterior external vertebral venous plexus. And of course, if you have an external something, you're going to have something internal as well, and that's exactly what you see here. Here's the anterior and posterior internal vertebral venous plexus. Next is going to be the musculature of the back. We're going to identify some of the muscles of the back and try and understand what they do, so what's their function, based on from where to where they go, so their origin and insertion, or proximal and distal attachment. Also, we're going to try and associate the innervation and the vasculature. Already on the surface anatomy, we can recognize a couple of features that might be important for us. So we have back here the nuchal groove. That's where the so-called nuchal ligament sits. The most prominent vertebrae is C7, vertebra prominence. If you think about the medial border of the scapulae, there's going to be right here is a well-defined rhomboid. You have this furrow called the posterior median furrow, the outline of the widest muscle, which is the latissimus dorsi. The erector spinae muscles actually run all the way up and down. They help keep us in the upright posture. And then down here, in people that are a little bit leaner, especially, you can see these dimples. They show the position of the posterior superior iliac spines at about S2. Then you have here the posterior side of the sacrum, and this here, if you are wondering, that's actually called the intergluteal cleft, not crack. D, T, and A actually shows that there are three different fiber directions of the trapezius. You have ascending fibers, transverse fibers, and descending fibers. This is all the same muscle. However, depending on which direction or which part of this muscle is engaged, it'll lead to different actions. Like you can pull your shoulders up, you can depress your shoulders, or you can pull them back. Okay, so elevation, depression, and retraction, I believe it should be. So we can subdivide this a little bit further into superficial extrinsic muscles who primarily function to produce and control limb movement. That would be, for instance, your trapezius, the lat dorsi, and the levator scapulae muscles. And the rhomboids, you have a major and a minor. You also have intermediate extrinsic muscles. They will function as superficial respiratory muscles. At least, you know what? That's kind of what a lot of people think. These are super thin. They're going to be easy to accidentally miss or destroy in lab. That will be the serratus posterior superior and the serratus posterior inferior. Then, of course, you have some deeper back muscles. Okay, so the intrinsic deep back muscles will function to maintain your posture and control movements of the vertebral column. Superficially, you're going to have some of these actually in the cervical region. You have the splenius, Spinous capitis, and Spleenius cervicis. It is doubtful that we're going to dissect these two in detail in the lab. However, we're going to find the intermediate group, which are the erector spinae muscles. They actually are the ILS muscles, or the I love spaghetti muscles, iliocostalis, longissimus, and spinalis. And then you have deep ones. This is the so-called transversospinalis muscle group. The semispinalis, multifidus, and rotatories. These are really small. They sit directly on the vertebrae. We will not dissect these. Interesting thing to mention about these, as these here are directly associated with the vertebral column, they're actually also going to be innervated directly by the dorsal rami of spinal nerves. Your trapezius is innervated by the spinal accessory nerve. It functions to elevate, depress, and retract the scapula. Blood supply is by an artery called the transverse cervical artery. The widest, the latissimus dorsi, especially pronounced in people who row a lot, innervated by the thoracodorsal nerve. Its function is to adduct the upper extremity, to internally rotate the upper extremity, and the blood supplies by the thoracodorsal artery. The levator scapulae. This is a good example of how the name implies what its game is, so to say. The levator scapulae elevates the scapula. Duh, you might think. Its innervation is by the dorsal scapular nerve, and its blood supply is by the dorsal scapular artery. The rhomboids. So, once again, if you encounter anything that's called a major or a minor, you know there has to be a major as well. If you encounter something called the superficial, there's probably going to be something that's called deep or at least intermediate. If you encounter something that is called superior, there better be something inferior, right? So it's all going to come together slowly. We have the rhomboid minor that sits on top, and the rhomboid major sits below. These are both innervated by the dorsal scapular nerve. Their function is to retract and rotate the scapula, but also to fix the scapula to the thoracic wall. The blood supply comes from the dorsal scapular artery. The rotation of the scapula is a little more intricate than one might expect, or at least than one might wish for. The trapezius has these superior and inferior fibers that cause superior rotation of the scapula. Rhomboids attaching here can cause inferior rotation of the scapula. Serratus posterior muscles. Innervation. Second to fifth intercostal nerve. Its function is to elevate the ribs. And I said earlier that it is a respiratory muscle. Well, this is super thin. Seriously, it's like maybe a couple millimeters if you're lucky. And yes, if it pulls up like this here, it'll elevate the ribs. This one actually is going to depress the ribs. They're called accessory respiratory muscles because by acting on the ribs and the rib spaces, it's going to change the size and shape of the rib cage, which means they aid in respiration. Splenius muscles. Your splenius muscles, like the Spinous cervices and the Spleenius capitis, they're innervated by posterior rami of spinal nerves. Their function is to help extend your head and the neck together, but also to laterally flex and rotate the head alone. Blood supply is going to be from a couple of muscular branches of the aorta and some branches of the posterior intercostal arteries. The I love spaghetti muscles, ILS, or if you're into flying, instrument landing system. Iliocostalis, from lateral to medial. longissimus, the longest in the body, and spinalis sits directly on the spines of the vertebrae. These are deep back muscles. They are innervated directly by dorsal rami of spinal nerves. Okay, no named nerves like nerves that have gone through plexi like the brachial plexus or the lumbar plexus. These are just directly innervated by the corresponding posterior or dorsal rami of the spinal nerves at the corresponding level. Function is to laterally flex the column. If they contract only on one side, like on the left, if they contract and shorten, they're going to bend you to the side that is lateral flexion. Yeah, and also they will help control flexion of the spine by lengthening its fibers bilaterally. Blood supply is by branches of the aorta. Now let's talk briefly about back sprains and strains, and then also about some injuries. Sprains are injuries to the ligaments. They occur without fracture or dislocation, and they can occur from excessive extension or rotation. A strain is stretching or tearing of muscle. Usually this happens in the lumbar region and involves the erector spinae muscles. Most commonly, that is the cause of lower back pain. For instance, unbalanced weight on the vertebral column will pull your muscles. That means you have spasms occur. If you stand a lot, especially if you're tall and you work bent over like at a dissecting table, this bent over posture can lead to back spasms. Trust me, it's true. Disc herniation. This is a transverse MRI in the lumbar region. What I can see here are deep back muscles, erector spinae muscles. That's the vertebral canal. This is a little bit of a herniated disc. This is part of a zygapophyseal joint. That's the spinous process. These would be the laminae. Okay, and that's the body of the vertebrae. If we have a look over here, lumbar vertebrae. This is L5. That's actually S1. You can see here, squishing out is the nucleus pulposus that is between L5 and S1. And that is going to lead to pretty severe back pain because it will be compressing spinal nerves. The rule of thumb is if you have a disc herniate between, for instance, L4 and L5, it's going to compress the L5 nerve. If it's between L5 and S1, it's going to compress the nerve below, so S1. Here's a diagram of a transverse and a median section. You can see here is the cauda equina, or the horse's tail. Remember that after the spinal cord itself ends, all the loose spinal nerves keep dangling down. They form something that's called the horse's tail because it looks a little bit like that, and it hangs into the vertebral canal. However, if you now have a herniation of a nucleus pulposus, that means you have a defect in the annulus fibrosus. It'll squish down and squeeze onto nerve roots. And as I said earlier, usually it is the one, well, named below the level of where the herniation occurs. Here you can see it as well. This is a posterolateral herniation, so is this here. Here's another condition called spondylolysis. That's a mouthful, isn't it, huh? Spondylolysis. Actually, it's also called Scotty dog syndrome. Why is it called Scotty dog syndrome? Because it is due to the fracture of a part called the pars interarticularis. Okay, so the interarticular parts of vertebrae, for instance, of the laminae of vertebrae, let's say L5. Okay, well, you'd have a unilateral fracture here, and that can develop either because of embryonic failure or due to trauma. And this here can lead, this is only unilateral, right? Can lead to a different condition called spondylolisthesis on the next slide. But have a look here. Your Scotty dog syndrome, it's called Scotty dog because if you hold a vertebrae just in the right orientation, you can draw the outline, and it looks like one of these little Scotch terriers, a Scotty dog. And sadly enough, in spondylolysis, Here it's okay, but in spondylolysis, Scotty Dog has a broken neck, and this can actually lead then to spondylolisthesis on the next slide. Spondylolisthesis, okay, spondylolisthesis is a bilateral fracture of the pars interarticularis, okay. What can happen then is that you have a displacement of the vertebral body, as you can see here in the example of spondylolisthesis at L5, S1. You see L5 will slide forwards, causing pressure on the spinal nerves of the cauda equina. You can see it also in this median MRI here. And in addition to that, you can see it quite dramatically reduces the opening of the pelvic inlet. Spina bifida is a condition where the, vertebral lamina fail to normally fuse. They're actually the embryonic neural arches, and often that happens between L5 and S1. In brief, this is usually not going to happen in a first world country because there are prenatal vitamins, especially folic acid is important to prevent this from happening. However, if in this bony defect, and it's actually present in up to 24% of people, most of the time it is, if it's just between those two vertebrae, not much happens actually, and it's concealed by skin, but often you'll find a little bit of a tuft of hair on the outside that indicates that that's the problem there. In severe types, as you can see down here though, like spina bifida cystica, there the problem is that you have one or more of these vertebral arches that may almost completely fail to develop. And spina bifida cystica is going to be associated with herniation of the meninges that forms a meningocele. Yeah. So you have the arachnoid and the dura herniating out here. And, or the spinal cord even, that means you would have a meningomyelocele, so you have some of the spinal cord even herniate into there. That, is very severe and can have a lot of neurological symptoms. In severe cases of meningomyelocele, for instance, you'd have paralysis of the limbs and disturbances in bladder and bowel control. Lumbar puncture. To do a lumbar puncture or a spinal tap, this is an aseptic procedure. It's usually done somewhere between L3 and L4 or L4 and L5. And the order of structures you would penetrate would be first skin, then your subcutaneous tissue, then the supraspinous ligament, the interspinous ligament, and then you would end up in the epidural space. And after the epidural space, because it's a potential space, you would hit the dural sac. The dura is pretty tough. That would actually create a pop. And then you end up in the subarachnoid space where CSF is. Theoretically, some say that there are 2 pops or 2 points of resistance while you're sticking the needle in to do a lumbar puncture. The first one would actually be the ligamentum flavum, and the second one would actually then be the dura. Other nerve blocks, you can do a transsacral or epidural anesthesia, very popular to aid in the pain with childbirth. You can do transsacral epidural anesthesia, going through the through the sacral foramina, of course. You can do a caudal epidural anesthesia. And so here in these cases, you would actually have a direct effect of the spinal nerves of the cauda equina as they exit the dural sac. It can also be done in the sacral canal, back here through the posterior sacral foramina, as we have here, or through the sacral hiatus. That's the end of the lecture. There's another back lecture on here that you can use to supplement if you want to. Otherwise, we should be in good shape if you read up on the dissector for the lab. Thank you for your attention.